request Amol also to remain because the next session will be very interesting. And I invite Chairperson Dr. Vipul Rathod, Dr. Naresh Bhatt, Dr. Yogesh Batra, and Dr. R.K. Wadhwa to start the proceeding. And this is our last session. And I request all participants to stay on time so we can finish the conference on time. Thank you. And I hand over the proceeding to the chairperson for next session. Thank you.
Thank you, Rajesh. This next session is dedicated to pancreatic fluid collections. And the first speaker is Shyam Vadraju from Chennai or Florida, whichever way he likes it. But he's going to give us an update on the status of management of PFCs as on today, and it will be followed by panel discussion led by Pramod Kar. Shyam, all yours.
Thank you, Naresh. Thanks to Rajesh and Vinay for this kind invitation. So my talk is on pancreatic fluid collections this morning, and without much ado, let me share my screen. So with pancreatic fluid collections, we know that everything begins and ends with the Atlanta classifications. We get this right, I think we have our treatment outcomes correct. If this is wrong, then things go wrong. So when a fluid collection is less than 4 weeks, we call it either an acute fluid collection or an acute necrotic collection. And after 4 weeks, this can become either a sterile or an infective pseudocyst, and likewise, infective or a sterile walled off necrosis that can be in the pancreas, outside the pancreas, or a combination of both. And the distinction is important because when you're looking at a pseudocyst treatment, the clinical success rate is quite high. It's more than 90% versus about 60 to 70% with necrosis, at least to old literature. Likewise, the complication rates are significantly high. Following instrumentation for necrotic collections, the number of interventions are higher. Patients stay in the hospital for a longer time, and the treatment for necrotic collections is much more expensive as compared to a pseudocyst, where the outcomes are generally favorable. Pseudocyst determination is quite straightforward. It's an anechoic collection. You find it uniformly homogeneous. The surrounding pancreas is fairly normal. There could be some calcifications in the pancreas, and on sonographic view on EVAs, you don't see any debris. These collections, when drained, will give you a stock-colored fluid with following stent placement has good outcomes. The pseudocyst can be drained with lamps or plastic stent. The advantage of stent is it's very easy to place, but unfortunately it's more costly. Given the complications and the adverse event profile, the luminal posing stent cannot be left in situ. It has to be removed within a 1 month time frame, and this could be a disadvantageous in situations with a disconnected duct where the fluid collection can recur. A plastic stent placement is, on the other hand, is a multi-step technique. You have to have some background in ERCPs to perform the technical maneuvers. It's less costly. The plastic stent, even if the patient is non-compliant or they have a disconnected duct, can be left in situ indefinitely to drain the disconnected gland, and the clinical outcomes are quite comparable to luminal-posing metal stents. So I think the literature on pseudocyst drainage is fairly straightforward. Endoscopy is the preferred modality when the fluid collection is accessible and the outcomes are superior to all other modalities in the interdisciplinary fashion. We also know that plastic stents are more cost-effective than luminal-posing metal stents, at least for management of pancreatic pseudosis. So given the lack of much controversy, we'll next move on to walled off necrosis. There are several features that will determine the success of interventions in walled off necrosis. Here you've got a walled off necrosis fluid collection that is very linear in size, but the degree of necrosis is very less. It's only 33%. Here's another collection where peripherally it looks fairly all right, but in the middle you've got a lot of necrotic debris with air in the collection with about 70% necrosis. And here is a collection on MRI that shows you about more than 90% necrosis. And this is important because the need for necrosectomy progressively increases with the degree of necrosis within a collection. Second is, we have some data to show that if the proportion of necrosis is less than 10%, in a single session of transmural drainage, the outcome is good. There's unlikely to be a need for necrosectomy. But as the degree of necrosis increases, so does the need for increased endoscopic sessions and necrosectomy as well. And in a randomized trial from the Dutch pancreatitis study group, it clearly shows that when patients are allocated to the step-up approach, about a third of patients will not require anything except a transmural or a percutaneous drainage, whereas the vast majority may require an endoscopic necrosectomy or a laparoscopic debridement. But once again, 33% of patients will do fairly well with just transmural drainage. Wall maturity is important to determine before we drain a collection. In this particular case, we can see an immature collection near the pancreas, but there is no walls around the collection at all. And here we can't do anything except maybe place a percutaneous drain, and even that is not recommended. In this particular case, we have got a wall that is fairly immature. It's okay to drain this collection very cautiously because on the inferior pole of the collection near the pancreas, the wall is still not well formed and there's a potential for leakage. And in this case, it's a classic example of a walled off necrosis where you've got a nice thin encapsulation that can be drained without a problem. So the timing to intervention will be determined by the maturity of the fluid collection. There used to be a dictum that we should never drain collections less than 4 weeks because they are all immature, but that teaching may not hold truth anymore. In this study from the Minnesota group, they have shown that you can drain these collections fairly safely, except that there's likely to be a more possibility of infection. These patients may have acute kidney failure and shock if intervened in the early phase, but the outcomes are pretty good. They generally may stay in the hospital for a longer time, may require an ICU stay and an acute collection when intervened, but the outcomes appear to be as good as your walled off necrosis. The number of collections are important. Here you find a single collection that can be fairly drained by a single transmural tract in the stomach. We've got a collection like this where you've got no communication between the collections and you're not sure what is exactly responsible for the symptoms of the patient, then you're obliged to do what we call a multi-gate technique where both collections should be drained, particularly if they are larger than 6 to 8 centimeters and there is any air in the fluid collection. So the number of collection will also determine the technique to intervene. The extent of collections is important. Here you see another fluid collection with air within the collection. So this is clearly an infection and you've got a thick septation. So if you're just going to drain it with a single tract, there is going to be inadequate drainage. So this patient, in addition to your transgastric drainage, will require necrosectomy beyond the septation for adequate drainage of the necrotic material. In this particular case, we have a fluid collection next to the stomach causing a gastric compression. But equally important is a collection in the lower abdomen and pelvis that is not communicating with a larger collection by the stomach. This patient will require what we call the dual modality treatment, where in addition to transgastric drainage, you will require a percutaneous drainage or a ward for evacuating the necrotic debris in the lower abdomen and pelvis. In this particular case, there is no role for endoscopic intervention. The fluid collection is all relegated to the lower abdomen pelvis, and this collection can be drained only by a laparoscopic surgeon through minimally invasive techniques or at least by means of percutaneous drain placement and a subsequent percutaneous endoscopic necrosectomy. So these slides would have shown you the maturity of the collection, the number of collections, the extent of collection, the degree of necrosis, why a multidisciplinary approach to intervention is important. Endoscopy alone, it is very unlikely that we are going to have an optimal clinical outcome. Another factor that's important is a disconnected pancreatic duct syndrome. In this patient, the extent of pancreatic necrosis is quite severe, but what you will find is that the pancreas is fairly well preserved and is just floating within a necrotic collection. But unfortunately, the middle of the pancreas has been necrosed and giving rise to a disconnected duct. And in a few weeks, when you follow up with a CT scan, there are going to be 2 pancreases, one communicating via the papilla, and the second pancreas that is towards the tail is going to be totally disconnected. In this particular case, we have got a fairly preserved body in the tail, but the head of the pancreas is completely cut off with the Uncinate process. And this patient, in my opinion, will require an indwelling plastic stent of the collection small, so that when the collection is drained out completely, the body and the tail will have a conduit for drainage to the stomach indefinitely. And even if the plastic stent migrates over a period of time, a permanent fistula would have hopefully formed to facilitate drainage of the distal pancreas. In this particular case, it doesn't matter what we use to drain, whether a metal or a plastic stent, because there's no pancreas left, and all that we have is a necrotic collection in possibly a brittle diabetic patient. So the disconnected duct again will determine the choice of endoprosthesis to management. And disconnected duct is important because we have clearly shown in a study of 330 patients that when you have a disconnected duct, the number of the proportion of patients who will require multidisciplinary approach or advanced intervention is significantly higher than when you don't have a disconnected duct. The need for reintervention is also significantly higher, and also the need for adjuvant surgery or what we call rescue surgery is significantly high when you have a disconnected duct in a patient. So how do you approach endoscopic management in the era of multiple endoprosthesis availability? This is a very simplistic algorithm that you should take with a pinch of salt that has been modified from a previous proposal that we submitted in 2015 where we had only plastic stems. So for example, if you've got a simple pseudocyst like this, We just use a plastic stent if the patient is going to be non-compliant, and we are not going to expect the patient to come see us back. Everybody else will use a lumen-opposing metal stent, and we believe this will give a 90% success rate. If you're going to see an index collection that is just unilocular, very close to the stomach, such as this, then a single gate technique using a lumen-opposing metal stent, preferably 20 millimeter in dimension, given the extent of necrosis, should be okay to handle this patient. If you've got multiple collections such as this that are clearly not communicating with each other and are discrete, then this patient will require a multi-gate technique. And we prefer to place 2 lumen-opposing metal stents to both collections to facilitate early drainage. If you're going to have a disconnected pancreatic duct syndrome, then there are 2 options. If the fluid collection is more than 10 centimeter, then what we do is to place a lumen-opposing metal stent more distally to the stomach. And then we place a second plastic stent through the distal place, which will be corresponding to the proximal stomach. And the reason we do that is I've shown you data already that patients with disconnected ducts do not routinely respond well to just conventional management. They require more drainage. So 2 tracks will be good. Second is, we always need an indwelling prosthesis in these patients to decrease the rate of fluid collection recurrence. So when the patient comes back in 3 to 4 weeks, we will remove the lumen-opposing metal stent and leave the plastic stent to indwell indefinitely. Also, when you place a lumen-opposing metal stent through the distal stomach, through the antrum, it gives a much better conduit to perform an endoscopic necrosectomy, should that be required, than approaching the fluid collection more proximally through the gastric cardia. On the other hand, if the disconnected duct and the fluid collection is only 6 to 10 centimeters, then probably this collection will not be amenable for drainage through 2 tracks. Then we just place a single lumen-opposing metal stent, and we come back early in 3 weeks, remove the lumen-opposing stent, replace it with and exchange it for a plastic stent to facilitate drainage of the disconnected gland. If you've got a fluid collection like this that is not communicating with each other, and there's a large collection in the pelvis that is also this patient will require dual modality, where we drain them transgastrically and ask our radiology colleagues to place a 14 French percutaneous drain for subsequent drainage and a necrosectomy if required. Does this algorithm work? We are looking at a sample of 425 patients, 220 using the plastic stents, where we use the different modalities, and the remaining 205 patients through a lumen-opposing metal stent using the algorithm that I have outlined above. All this data has been collected prospectively, and we're doing the analysis, and hopefully we will be able to share the data very soon. But preliminary data tells us that metal and plastic stents appear to work equally good, except that maybe when you use lumen-opposing metal stents, the number of interventions required for treatment success is significantly less compared to those of plastic stents, even using algorithmic approach. And then this is a study that we published that compares lumen-opposing metal and plastic stents for management of vault of necrosis. And as I've told you earlier, in the sample of 60 patients, we did not find any difference between both stent cohorts, except that the procedural duration was significantly shorter for lumen-opposing metal as compared to a plastic stent approach. And I think subsequent studies published in the forms of meta-analysis has subsequently proven this to be true. One other note that everybody is probably aware is, during our initial randomized trial, we realized that if lumen-opposing stents are left behind for a prolonged period, after 3 to 4 weeks, we can have complications such as bleeding or bleary stricture formation or a buried stent syndrome in these patients. And therefore, these stents should be removed in a timely manner within 3 to 4 weeks so that they do not impinge on the regional vasculature, giving rise to complications. So in 3 to 4 weeks, they require a CT scan followed by stent exchange or removal, depending on the status of the pancreatic duct. In my opinion, if the fluid collection has got more than 33% necrosis, I always prefer to use a 20 millimeter lumen-opposing stent. And the reason is because this facilitates index necrosectomy without the need for the stent to progressively dilate itself through the tract. If the fluid collection is more than 10 millimeter from the transducer, then we use a lumen-opposing metal stent with a saddle length that is 15 millimeter to minimize the risk of stent migration as the fluid collection collapses. What are the factors that are associated with adverse events in LAMS? We found that after 3 to 4 weeks, yes, we have a problem. In addition to that, we found that the fluid collection is less than 7 centimeter. Then these are the collections that more likely will bleed. If the fluid collection is more than 7 centimeter, there's always a little bit of necrotic debris that prevents complete collapse of the cavity and friction of the stent with the regional vasculature. So these 2 factors are important and will give you an approximate idea on when adverse events happens following LAMS placement. And finally, we found that we wanted to study the relationship between fluid collection recurrence in the era of LAMS placement and in the setting of a disconnected duct. And what we found is that if you really have a disconnected duct, and this should be ascertained after the fluid collection recurrence, because index, when the patient presents with a collection, yeah, MRI is unlikely to be an accurate modality because of the presence of fluid collection. The signaling will not show the status of the main pancreatic duct. So once the fluid collection resolves, you do a MRI or a ERCP to look at the status of the pancreatic duct. And if there's a disconnected duct, then the lamps must be replaced with a plastic stent. And this is the only independent factor that was found to be significant when recurrence is encountered in walled-off necrosis in the setting of disconnected ducts. My last two slides are on necrosectomy. There's a lot of controversy on when you perform necrosectomy. We do not perform index necrosectomy at all. The only time we will perform a necrosectomy at the index intervention is when there's extensive amount of necrosis, and when you place a stent and there is nothing you can see endoscopically in the form of drainage, then we are very concerned that a sterile necrosis will become infective. Then in that case, after 20 millimeter lamps is placed, we perform an index necrosectomy. In other patients, we look for symptoms such as sepsis, SIRS, new onset organ failure, or failure to resolution of all these factors at 72 hours. At 72 hours, if all these factors continue to persist, then we will perform endoscopic necrosectomy through the index tract through which the lumen-opposing metal stent had been placed. And when we perform necrosectomy, if you anticipate the need, it's very important not to place the lumen-opposing stent in the proximal portions of the portions of the collection, because if you go through the proximal stomach, I think passing the gastroscope through the gastric cardia is going to be extremely challenging. So it's always important to place the stent in the distal stomach should we anticipate a need for necrosectomy. And I think there's a method to the madness of necrosectomy. The step one includes, we use a hot snare for adherent debris. The important thing is to pull the snare to make sure it's not entangled in vasculature. A cold snare can be used for everything else, and a wide jaw rat tooth forceps if the debris would not come out easily. For extraction, we use snares, and we always fit the therapeutic gastroscope with a cap so that the snares, so that the debris can be drawn into the snare. You can also use an alligator forceps if required, but the nets for some reason are totally not helpful. Some people use gentamicin. We used to use gentamicin mixed with normal saline, but there's no data to prove that it helps at all. But hydrogen peroxide can be used, but this should be used only at the termination of the procedure. Because if you use it during the initial parts of the procedure, it produces so much air bubbles and froth that it is not able, that you are not able to see the vasculature and so forth, and complications can occur. So when at the termination of the procedure, you use hydrogen peroxide to make sure that the cavity is well sterilized. Does this work? I think it is very subjective. At least in a study, we have shown that if you use the algorithmic approach, that for necrosectomy, we have fairly good outcomes than to just go randomly and try to perform a necrosectomy using a combination of non-evidence-based techniques. But I think most of those questions, reasonable questions, have been answered in the endoscopic literature for necrosis. I think the most important study that needs to be performed is a randomized trial, where we compare a step-up approach, where you place a drainage, where you place a lumen-opposing stent, and then you advance and your techniques until there is a resolution of necrosis and symptoms, or you perform a direct endoscopic necrosectomy. And the primary outcome measure should be treatment success, which should be resolution of the collection at 6 to 8 weeks with a need for minimum number of interventions. And I think if this question is addressed, we would have achieved a lot that should have been achieved in this area. So thank you.
Thank you. Thank you, Shyam. A couple of questions. Simple question: is there any absolute contraindication to a plastic stent, and that you recommended only a LAMS? And two is, if you have multiple fluid collections, is it necessary to drain all of them, or how do you take a decision based on size or position? How do you decide that?
I think the plastic stent issue, Naresh, is pretty straightforward. I don't think there's a situation where a plastic stent is contraindicated. We have been using it forever, it works well. I think we're all spoiled because the lumen-opposing stent is easy to deploy. I think you can use a plastic as long as you dilate the tract adequately. It may be a little cumbersome, but I think a plastic stent is okay. As far as your second question, can you repeat the question?
Multiple fluid collections.
There's no evidence at all, Naresh, that all fluid collection should be drained. I would think the only situation where they should likely be mandated is we got 2 large collections or 3 large collections, and each of them are infected with a lot of air bubbles in each of them. That tells you it's clearly an infection. And if you've got access, then I think it makes a lot of reasonable sense. Otherwise, you can just drain the largest collection and wait to see what happens. And if the patient gets better, you just leave it alone. But if there's definitely demonstrable infection and the collections are clearly discrete from each other, and if you can access them endoscopically or through percutaneous techniques, then I think it's reasonable to drain them all.
May I ask one question, Shyam? Shyam, I want to know how difficult it is to put a plastic stent when you need a plastic stent after removal of a lambs, especially when the cavity is completely collapsed. And how would you ensure that the guide wire is not going to probably injure a vessel or vascular structure in the cavity?
You got it right, Vipul. I mean, you nailed it. I think if that's the reason that whenever possible, I always try to put up a metal stent and a plastic stent so they're 3 at different track. So that, because I'm always worried that after the lambs is removed, the cavity is gone and I don't have access, and the patient will come in 4 months with a 4-centimeter collection. That collection may not even cause symptoms, but then your surgeon is calling and telling you, well, I have no other explanation for pain and so forth. So that is the reason to do your dual drainage if possible. Otherwise, if you're just going through the index tract and there's a lot of necrosis, preferably I don't think we should wait for 5 weeks and 6 weeks when the collection is as small as 3 centimeter and the cavity is not collapsed completely, which usually corresponds through the 3-week time frame. We should go and remove it, maybe dilate it and just put a plastic stent just to secure the cavity. And there are a group of patients, I can promise you that probably there's a small cohort of patients when you go back in a couple of weeks, even in 3 weeks, the cavity is so fully collapsed, you can't do anything except pull the stent, and you can't do anything because when you push your guide wire, it just falls back at you.
And is the size of the double pigtail which you place behind, do you have any preference for the size of the stent, double pigtail?
No, we know that through a Endoscope, the 7 French double pigtail works better and it's easier to push. So we always prefer to place a 7 French 4 or 7 French 3 centimeter double pigtail.
Thank you.
Another question, Shyam, is what are your tricks to prevent an internal migration of your plastic stent?
Internal, no tricks, Naresh. There's absolutely no tricks at all. The thing is not to, in the index session, there are a few things you can do. You shouldn't dilate the tract excessively. Sometimes you have to. Say, for example, you've got a walled up necrosis. It's very huge. There's so much debris. And you dilate it and the stent migrates. So what? You can go with a gastroscope and pull the stent back. The problem happens with the pseudosystem. It's a nice, clear anechoic collection. You're dilating to 8 millimeter and then it migrates. Then it becomes a major problem. In those situations, I don't think we should dilate to more than 10 millimeter or 12 millimeters of the pseudosystem. And then you deploy the stent. Looking at the stent and putting the mark more proximally or middle is important than towards the tail of the stent, because that's when you push excessively, it migrates. Another place where it migrates is through the gastric cardia on the stomach, because your scope is fairly straight and it's like a gravity. When you push in, you can see the stent going straight into the collection and you feel so ineffective. So when you're going through the distal esophagus or the gastric cardia, I think I always prefer to get the initial part of the stent and to pull my scope like crazy and ensure that a lot of the stent is lying in the stomach and not in the collection. Beyond that, there's no scientific data I can give you to prevent migration.
One last question, Shyam. You said
Dr.
just one more question. He said about the prospective agenda for research. We know that surgical data has shown, Shyam, that the step-up approach is helpful for the overall outcome of this infected one. So I want to know from you in which way endoscopic approach of direct necrosectomy and a pilot endoscopy will change the outcomes. Because we know that endotoxemia sets in because of very aggressive necrosectomy.
Yeah, if you ask Pramod, whenever I get very enthusiastic, I always look at Pramod Garg's gastro paper. And it's like a slap on my face where he will tell you, leave them alone for a while and you don't need to do nothing. And when you read it, it gives you a touch of reality. We know that 35% of the time, our judgment is flawed, and then we think we need to do all these things, and you just place a stent and they get better. So that's a significant proportion of patients where you don't need to do anything at all, except maybe transmural drainage. That's why I think in a cohort of patients in a multi-center fashion, if you really think that they need to be intervened, they're doing a randomized trial, will probably give us an idea. I agree with you. I don't, unless you do a subset analysis on a big cohort, we will never be able to say who really requires direct. But if you look at the whole cohort of patients, we may get an idea and say, well, 70% to 90% success rate can be achieved with index necrosectomy versus 76% by a step-up approach, at least for endoscopic techniques. But agree with you, it will not be a perfect study.
Thank you.